So moving on, we're going to be talking about the not too happy topic, but one which needs to be addressed, which is liver transplantation for PSC patients. And this is going to be given by Jennifer Guy from California Pacific Medical Center, where she's the director of the liver cancer program and is a very experienced transplant hepatologist. Look forward to the talk on liver transplantation and PSC, Jennifer. Thank you.
Thank you. Good afternoon. I wanted to first thank Dr. Bowles for inviting me today to speak. It's a real pleasure to be speaking to patients and caregivers about something we're all passionate about, which is liver health. And I also wanted to thank the PSC partnership. I've been really impressed with the intention and vision of this meeting, and I think it really shows that as an organization you have your eye on the ball, and it's really exciting to be here today. So, yes, thank you. So I get to talk about liver transplant for patients with PSC, and I wanted to start by telling you why I am a liver transplant physician. And this goes back over past 15 years ago, in the times before cell phones where we would wear pagers, and I was a brand new doctor, and when you know you've made it through medical school when you get a pager and you're a doctor, and then what happens is before cell phones you had like a lot of pagers, so I would get like 4 pagers and I was like armed and ready to go, and then the pagers start going off and you're like, oh my goodness, this is a lot of calls. But I went in those first months of being a new doctor I was at UCSF and I went on the transplant service at UCSF, and I felt like I was at home. It was an amazing experience because every single person that I worked with, from the patient, the caregiver, the nurses, the surgeons, and the hepatologists, and Marion Peters was the hepatologist I worked with, everyone was on the same path, and that was to do anything possible to help the patient in front of them. And everyone believed in the patient and what we could do for them. And we worked really hard to define what success looked like for a patient by listening and by talking and by figuring it out. And then if we couldn't get to success, this was a liver transplant unit we were on, if success looked like transplant, that's where we were headed. But if success didn't look like transplant, we were still headed toward what that definition of success was. So we're going to talk about transplant today, but transplant does not apply to everyone. But defining what success looks like for all of you and for us as physicians, that does apply. So just to remember that as we move forward. So these are the questions we're going to talk about. Who needs a liver transplant for PSC? What is a liver transplant? How do I get one? And what is life like after transplant? So we've talked a lot about the different things that can happen as a manifestation of PSC. And in liver transplant, there are 3 different ways people come to liver transplant when they have PSC. The first is thinking about a normal liver looking like a peach, and when it starts to scar, it turns into what looks like a cauliflower. It gets hard. And when it's scarred, it starts to have trouble doing its jobs. And in that situation, once you get to cirrhosis that is symptomatic, that is a time for people to start thinking about transplant. The other thing we see is that, is this working over here? Yeah. The other thing we see is cholangitis, which is inflammation, scars the bile ducts. They have a propensity, therefore, to get infected. And if they have more and more infections, cholangitis can occur, and that's another indication for liver transplant. Finally, as Arpana mentioned, cholangiocarcinoma, which is an abnormal proliferation of cells within the bile duct that then turns into cancer, can also be an indication for liver transplant in certain people, depending on the specifics of their cancer. So, how do we determine then the severity of cirrhosis? And we've talked a lot today about varices and encephalopathy and ascites, but what does that really mean? And I think one thing to do is to think about a picture here. The liver, when it gets scarred to that cauliflower-like situation, there's increased resistance. It's not soft and fleshy like a peach, like a normal liver, and so then there's resistance. And then backflow backs up, and that's this idea of this is the Hoover Dam. And this idea of this would be the liver where there's backflow, i.e. the dam, and all of the pressure of the water, i.e. the fluid and the blood behind us in the portal vein, as we have mentioned, backs up. And then people can get ascites. And then it still's got to get back to the heart, all this blood, and so then it starts to take a detour. And it goes through the spleen, and your spleen gets big, and it goes up through abnormal blood vessels in the esophagus, and varices can happen. And then encephalopathy can happen because the blood's not flowing through the liver to get clean, but it's going on a detour. So those are the reasons why in cirrhosis you get those manifestations, and those manifestations are things that then show us that your liver has gone from a place of scarred but doing its jobs to going to a place where it's scarred and it's not doing its jobs very well. And this is an idea. I have a 4-year-old, so we all draw, and so I had to do this drawing on my computer. I signed it like my 4-year-old does. So it's instead of going this way in a circuit, it's going this way in a circuit. And that leads to swelling, bleeding, jaundice, and confusion. And then there are some labs that correlate with some of these symptoms, and those labs go into the MELD score. And we've been talking about the MELD score. And the MELD score helps us to categorize how sick someone's liver is. And it's important in the discussion of transplant because this is how organs are allocated in this country, and we're going to come back to it. But the idea here is the MELD score predicts death from cirrhosis within a 3-month period. And it uses things like the INR, bilirubin, sodium, and creatinine. And over here is a graph of low MELD score, 100% alive, high MELD score, 100% not alive. So this is why we use this MELD score, is it helps us understand the severity of someone's disease once they have cirrhosis. Dr. Goel just talked about how do we know if we're going to get to cirrhosis, but this is once we're there, what is the prognosis? So this is a calculator that you can use, and we use all the time in our clinics to look at what is someone's MELD score. And so the question is, who needs a liver transplant when it comes to PSC? And I have mentioned that not everybody does. And so this is determined by their symptoms, cholangitis, MELD score. And in the United States, about 5% of all transplants are done for PSC. And 50 to 75% of patients with PSC on the wait list have cirrhosis. So it's most common that they have cirrhosis and complications that gets them onto the wait list. But 40% of patients will have had a history of prior cholangitis. And this does not separate out just cholangitis. Some of these people can have cirrhosis, and this data is not great, but it just gives you this idea that cirrhosis is an indication, cholangitis is an indication. And then once people are on the transplant list, they still obviously have a risk of recurrent cholangitis. And this graph is meant to show you, it's small, but the important number here is about 300, 250 to 300. And over the course of 20 years, this is the gray numbers are for PSC. The number of transplants for PSC haven't really changed. And this was alluded to, I think, by one of the physicians who spoke about the fact that even decreasing the alkaline phosphatase doesn't necessarily change the outcomes here. And so, the numbers are still the same. And it's also to say that about 300 patients a year in this country undergo transplant for PSC. So again, this is not a lot of people every year, but it's something we wanted to talk about to illustrate how this might be part of your journey. So what is a liver transplant? So I'm not a surgeon, but we spend a lot of time with surgeons, and so they have taught me a lot. And the idea here is that there are 2 different types of liver transplant. There's a deceased donor liver transplant, which I will explain first. And in this situation, someone passes away either from brain death or from death after a heart attack. And after that, what happens is their donor liver is given to a recipient. The recipient's liver is removed, and the donor liver is sewed in surgically. Here are 2 connections that connect the blood to the top of the body and the bottom of the body. The heart is up here. And then these 3 surgical connections are important. This is the bile duct, the hepatic artery, and the portal vein. So those are all sewed in as well. Sometimes with PSC, the bile duct is damaged in the main bile duct, the common bile duct, the trunk of the tree. And in that situation, they can't use that part of the bile duct. And when that is the case, what they do, and I'm going to show you in the next picture, is they bring a piece of intestine up here to connect the donor bile duct to the recipient's intestine. So this is a living donor liver transplant, and this is a different idea here in that there is a suitable living donor that is identified by the team, and that person needs to match by a blood type, by size, and needs to be very healthy. And in that situation, what happens is the donor goes to the operating room, and they're left, this is for adults, it's different for children sometimes, but the left side of the liver remains in the donor, whereas the right side of the liver is surgically removed and then sewed into the recipient here. Because the donor keeps their bile duct, the recipient needs to have a piece of intestine here brought up to be sewed into the bile duct. That's something called a Roux-en-Y hepatic angiogenostomy. Interestingly, when you look at PSC, about 5% of all deceased donor liver transplants are done for PSC as an indication. But when you look at living donor liver transplant, about 14% of living donor liver transplants are done for PSC. So this is a condition where living donor liver transplant is certainly an option, and people are going toward that option. So how do you get a liver transplant? So the first step in getting liver transplant is being referred to a transplant center. And Arpana talked about that. If you're starting to develop symptoms and you're recognizing, and your physicians are recognizing that it's time to move forward on the step of path of transplant, you're referred. And you come to the transplant center and you meet the team. And one of the reasons why I loved my first experience of transplant is because it is the ultimate definition of the team. And ultimate definition of team is everybody believes in what they're doing, and people really believe in the patient, and they put the patient at the center. So this patient and the caregivers are here, and this is the team around them: the liver doctor, the schedulers, the social worker, the financial coordinator, support group, other physicians, the nurses. And the idea here is that the patient comes to learn about liver transplant, about the MELD score, how allocation works, logistics, how do I feel after surgery, medications. And what the team is looking to do is to learn about the patient and learn about the patient's caregiver, medical conditions. And your goals are, do I understand why I want a transplant? Do I understand the risks and benefits of a transplant? How can I feel physically and how can I feel mentally before and after a transplant? What resources are available to me as I have questions? If I'm not feeling well, who do I call? And our goals are, one, we're asking ourselves, and I learned this from Marion, one, do you want a liver transplant? Two, do you need a liver transplant? And three, is there anything medically or socially that makes transplant too high risk for you? And those are the things that we're thinking about as the team when we're trying to make an evaluation of whether the patient should be placed on the liver transplant list. And so we have a committee of all those team members, and we meet, and we talk about these things. And there's an important point about liver transplant that is something that I've always found to be so interesting and challenging. And that is, as transplant physicians, we're trying to balance the idea of justice versus utility. And what justice means is the patient right in front of you. What is the best thing for that patient? Trying to treat every patient the same and allow them the same fair chance. Whereas utility is thinking about, in the setting of a scarce resource, how do you best optimize that outcome? And so we're thinking about the patient in front of us, but we're also thinking about the entire transplant community and the patients that aren't in front of us, but might be down the street at UCSF or Stanford or across the country. So once a patient is determined to be referred, evaluated, and listed, the next steps are to determine your priority on the wait list. And that is where that MELD score comes in that we talked about. Because the MELD score determines what someone's risk of dying in the next 90 days are. And so the sickest patient goes onto the top of the list and is the one that's going to be getting offers for organs. And the people whose MELD scores are less than that kind of go down on the list. And so the waiting list is made up of lots of people throughout our region, which I'm going to show you. And ultimately, once the MELD score is high, usually in our region, I'll show you in the 30s as an example, then people start to get matched up with organs. And I explain to people, it's the right liver for the right person at the right time. And people are like, what does that even mean? And it's like, exactly. It's because there's so many different pieces that go into when someone is going to get a transplant that the MELD score is a part of it, but there's more than that too, just from who else is sick in the area. So I showed you that. So we talked about the fact that the MELD score is a model for end-stage liver disease, so it categorizes people who have cirrhosis as the basis of their need for transplant. But what about the people who have cholangitis or who have cholangiocarcinoma, where their livers might be functioning fine with a low MELD score, but they have an indication for transplant? So in those situations, the transplant center can go to the United Network of Organ Sharing that overrides how organs are allocated. And there are boards, there's a regional review board, which I sit on currently, and you can petition and say, this patient has had multiple episodes of cholangitis, they've been in the ICU, they're on rotating antibiotics, they have a resistant organism, that VRE we talked about earlier is now in this patient's blood. Their risk of death is predicted to be 85% in the next 3 months, and therefore I request a MELD score of 30. And then the regional review board hears that, and then they decide if they're going to award that or not. There are also standard criteria for cholangiocarcinoma, which are very specific to the type of cholangiocarcinoma. But if the award is granted and that number is given, then that person gets to update that with a petition every 3 months. So many of you may have heard that the MELD score varies based on where you live, and there are some geographic differences that the transplant community is actively trying to think about currently. I like this slide because it brings up several points. Number one, that the United States at present is broken up into 11 regions. And so when we're here in California, we're in this region number 5, and that's how we are first thought about when we think about all that organ allocation. I met someone earlier from Washington, and so that's their region. Utah is in region 5. And the high MELD scores are here in red. In these regions, it means that on average, this is MELD allocation, meaning the MELD at transplant, this was through 2015, in California was above 30. Whereas if you were in any of these white areas, the average MELD at transplant was lower than that, in the low 20s. So sometimes people will ask, well, my MELD score is 25, I could be, if I lived here, I would be getting a transplant, but if I live here, I'm waiting. And you can be listed at several centers, and many people do try to investigate if that's an option for them. And my advice is always to just be sure who the quarterback of your team is if you are listed at different places, because you want to make sure that people are really remembering to keep you at the center of the conversation always. And finally, what is life like after transplant? So this is we've seen a lot of, I had to put like some graphs in here. And the idea here is that survival after transplant is excellent. This is data that went just through 2004, so this is old data, but you can see that the likelihood of surviving, this is the likelihood of being alive at 10 years, is higher for people who undergo transplant for PSC and PBC as compared to all the other causes. So people do very well after transplant. And just to show another tiny, tiny graph, you can't see any of this, thank you, Kiddis, for this. But bottom line is, at 5 years, 85% survival. So people do really well after transplant from a survival standpoint. But the other question I think is really important is thinking about, what is transplant like? What is life after transplant like? And many of you have probably gotten a chance to meet Dr. Jerome Schoferman, who's a very important person in my life, and he likes to say that liver transplant is a chronic treatment. I've been thinking about it as a chronic cure in some ways, but the idea being that there is a lot of work that goes into having a transplant and a lot of work after the fact. So you take medications to prevent rejection lifelong, and you take medications to prevent infection in the early months post-transplant. There's potential for side effects from these medications. So though you don't have PSC anymore, you have a chronic illness that requires some taking care of. The risk of PSC, as Arpana talked about at the panel, is about 25% by 5 years. And this can be a challenging thing to diagnose and a challenging thing to treat. But it's not an absolute, obviously. And surgical risks are low, but one thing that is important for people who have PSC and have been undergoing ERCPs potentially is that at the connection of the bile ducts, surgically, you can get a narrowing. sometimes because the bile ducts are different sizes from the recipient to the donor, and ultimately, sometimes those strictures need to have an ERCP with stenting. So I've had patients who have had PSC and then they have a stricture just like anyone else who gets a transplant can get a stricture, but it really hits them because they were like, I thought I was done with ERCPs. And the clinical course of IBD, many people with PSC have IBD as well, that course can be variable. Some people do really well with their IBD, other patients have symptomatic IBD after, and so it's just something to be aware of. And I think one of the things we've been talking about is, what does success look like? And we're talking about treatments and transplant, but also what does success look like in how I'm feeling with my chronic illness? And so it's an adjustment transplant from living with PSC to now living with the transplant. So that's something that we think a lot about, and we could, as physicians, do a better job of talking with our patients about. So finally, just talking about team, and I've mentioned that I think that transplant is a really important team, and all of you have figured out in your lives who are your teams, and you're here together as a team. And so what I've learned from my patients is that I really encourage my patients and their caregivers to be empowered to be their best advocates. And I think in a medical visit with my patients, I like it when they communicate their goals to me and they set their expectations. What do they expect of me? What do they expect of themselves? What do they expect of their health? And I think it's important to be open to hearing the good and the bad. It's hard, for sure, to be living with a chronic illness, and to be able to see the good and the bad during all this, I think is very helpful and hard. Taking notes is good because we like to talk fast. I really like to talk fast as an example. So there'll be a lot of things that are covered, and then you can think about them and make a list of questions and come back. And then if things aren't working, let your team know. I think a lot of times as a team, like, systems might not always be working in our favor, and so we need to know that there's a problem so we can fix it. The other systems problem that I think is important is that a lot of times we're like the last to know. Like they'll have a test done by a local doctor and we won't have the results. And so making sure, if you can, to write down when you're getting your test, if you can get a copy, to have a binder. I love it when people come into the room with a binder. And then backup plans should be discussed. If I'm sick, who do I call? Plan A is that we're going to take Urso and we're going to monitor my alkaline phosphatase, and it's going to go down and it's going to be great. But what's plan B? What if my MELD score is going up? What are we going to do about that? And then the other thing is, if you want straight talk, ask for it. I mean, there's sometimes physicians, they hold back because they're afraid to upset someone or bring up a difficult topic. But if you've got something on your mind, open it up so that you can all have that conversation. And then I think really importantly, and Marion touched on this, is know what resources are available. Obviously, this is an amazing resource having this group here. But nutrition, seeing the nutritionist, the social workers, there's a support group at our center. And I think the idea of mindfulness classes too. A lot of times, as we've talked about in terms of, for example, predicting how people are going to do and when they're going to get sick or if they're going to get sick, there's a lot of thinking about the future, and that can be very anxiety-provoking. So ways to kind of help keep us in the moment and appreciate what we have, because those things are things that we can control in that moment. So that's what I have. Thank you so much. Appreciate it.